So now let's study about blood physiology. Now there are two different parts. First is hemostasis and anticoagulation. So in surgical cases, first thing which required is prevention of bleeding, which is called as hemostasis, and anticoagulation is prevention of thrombosis. There are two different parallel things. One is bleeding and it is opposing to coagulation. So both these are acting opposite to each other. So we have to prevent bleeding with adequate coagulation and prevent excess coagulation. So we should have bleed to this is coagulation. So need to prevent thrombosis also. The blood should not coagulate, shouldn't coagulate in vessels. So that is called as thrombosis. So how is, if suppose there is an injury, a vessel is cut, the first thing is vasoconstriction. Second is platelets coming in blocking that clot. Platelet is adhering. Third is clot formation. So these are the three ways to prevent bleeding. And to prevent thrombosis, if the clot is formed, it is breaking down by fibrinolysis. Protein CNS is also again preventing the coagulation. Antithrombin activation is constantly preventing coagulation. So this is the important cell is required is platelet. It contains an alpha granule aggregation whenever this called as fibrinogen. Adhesion is caused by von Willebrand factor and fibronectin. Tissue repair is platelet derived growth factor. Inflammation is chemokine. So platelet is secreting the alpha granules which has got fibrinogen, fibronectin, platelet derived growth factor, inflammation cytokine, coagulation factor 5 and plasminogen activating inhibitor. Plasminogen activator inhibitor. Delta granules, serotonin helps in vasoconstriction, which secretes calcium and ATP, important platelet activation aggregation, and lysosome granules. So these are the different types of granules which are present from the platelets. So here you can see this. If there is disruption of endothelial surface, von Willebrand factor GP receptor causes platelet adhesion. Fibrinogen is secreted. Unplug the fibrinogen. They causes stimulate thrombosin to form the stable fibrin plugs, that is aggregation, and fibrinogen platelet. These are the two receptors by which it is causing platelet plug formation. Now blood coagulation, how it is done? By the two different ways, extrinsic and intrinsic. Intrinsic is by subendothelial damage, extrinsic by blood to tissues. This starts with factor 12. Intrinsic starts with factor 12. This is intrinsic pathway. This is extrinsic. Factor 12 is initiated first, then factor 11, factor 9, 8. These are activated factors. They cause factor 10 to activate. Factor 10 is the junction point for intrinsic and extrinsic. Extrinsic is whenever there is injury inside the tissues. Tissue factors come in contact and lead to activation of factor 7. They lead to formation of common pathway. This 10 is the common pathway. With the help of factor 5, labile factor, calcium, lipids, this is converted to prothrombin is the factor 2 is converted to thrombin. Then thrombin activates fibrinogen, which is soluble into insoluble fibrin clot. This is the longer pathway. This is smaller pathway. For the test of this pathway, APTT is done. and drugs which are acting against these pathways, heparin is acting here, warfarin is acting here, and some of the drugs are also acting in the prothrombin. So intrinsic pathway is tested by APTT, extrinsic pathway is tested by prothrombin time. So common pathway helps in polymerization, clot retraction by factor 13. So this is an fibrinolytic system. This now we have seen about coagulation. Now we want to prevent the coagulation. So this is anticoagulation. There are three important things. Fibrin clots are formed. Protein C prevents coagulation. Antithrombin prevents coagulation. Activation of antithrombin 3. Fibrinolytic system only causes lysis after thrombosis formed. Plasminogen, when activated by tissue, plasminogen activated to plasmin. Plasmin causes fibrinolysis, which dissolves the fibrin threads. Tranexamic acid is a drug which is used to activate plasminogen. So this is fibrin. It is broken down into by fibrinolysis by fibrino. This is plasminogen, plasmin, which is formed by plasminogen, and fibrin broken down into products. This is thromboxane. Tranexamic acid is acting here. Now this is one thing. Protein C and S is formed in liver as vitamin K dependent coagulation factors 10, 9, 7, 2. C and S, vitamin K, these are all dependent on this. 10, 9, 7, 2 means 10, 7, 2, 9. They are dependent on vitamin K. So warfarin is acting on vitamin K. So here secret bind to thrombin complexes activate. For this, C is activated. To activate C, protein S is used, then inactivation of factors. And antithrombin 3 prevents thrombus formation, binds to heparin causing complex. This combines with 9, 10, 11, 12 and 2. 9, 10, 11, 12 and 2. Trauma-induced coagulopathy, hyperfibrinolysis. Major activated protein C plays a critical role in coagulopathy. It is an anticoagulant effect by inactivating factor 5 and 8A and also promotes fibrinolysis, inhibiting tissue plasmin activator. So bleeding tendency can be seen in hemophilia, deficiency in factor 8 or wall-dependent factor 9. Deficiency factor mainly caused by chromosome hemophilia X-linked. So common in males. Acquired hemophilia is rare disease, autoimmune bleeding in the people. APTT is tested here. And one development factor which is glycoprotein. One is a glycoprotein. And this one is aid in platelet digestion, serves plasma carrier for. This is swab bleeding time in APTT with normal platelet test. Most commonly used in practice cryoprecipitate is required. What is hypercoagulability? Factor 5 laden. Most common genetic disease DVT. Antiphospholysis. Most common cause of DVT in pregnant patient. This is again question. Antiphospholipid disease with positive family history. Antithrombin 3 deficiency. This is treatment here is warfarin for life. Nephrotic syndrome has liability to coagulation due to protein C deficiency, factor 5 thrombosis. Descendant vascular coagulation. What is this? This is delay and clotting depletes the platelets and clotting factors needed to control excessive bleeding. Diagnosis is decreased fibrinogen, decreased platelet count, PT is increased, APTT is increased, D-dimer is increased, FDP is increased, infection, major trauma, sepsis, plasma, and vasopressor. Anticoagulation drug. Now to prevent anticoagulation, we have read Low molecular weight heparin depresses factor 10, no need of follow-up. So here doesn't need anything follow-up. N fraction heparin binds with antithrombin 3 and forms a complex with 2 9 INR. This APTT should be 3. Complications: bleeding, hepatic induced thrombocytopenia, hit 14 days. Antidote is protamine sulfate. Protamine sulfate is an antidote for heparin. Unfractionated heparin can be stopped before operation at 4 to 6 hours. Nothing you have to give for reversing. Low molecular heparin should be stopped at least 20 to 24 hours. Oral anticoagulants warfarin inhibits vitamin K and thereby inhibiting factor 2, 10, 9, 1972, 27, and 9. Here INR is tested, it should be 2 to 3 ratio. Here APT is TT is tested, it should be 2 to 3 normal. So warfarin toxicity may cause major bleeding tendencies. Then there may be stop warfarin, give vitamin K. If need bleeding, vitamin K stop, you have to give. Warfarin toxicity can be reversed by hemoglobin complex, reversal within 1 hour, rapid action. Vitamin K reversal 4 to 3 hours, oral vitamin K 4 or 24 hours. Fresh frozen plasma, preparation for surgery, stop warfarin 3 to 5 days before, and give low molecular heparin. So now coming to the part anemia. So this is an important part to understand. There are 3 different types of microcytic, macrocytic and normocytic. Whenever there is deficiency of iron, Fe, thalassemia, microcyte, folate, Fo, Phe is micro, Pho, Phe, E, micro, folate and B12 go hand in hand. Pernicious anemia is there. Gastrectomy, ileal resection, vegan diet. B12 is deficiency. Hemorrhage, anemia, chronic kidney disease, less erythropoietin, that will lead to spherocytosis, sickle cell anemia. Aplastic deficiency of all blood cells, sickle cell anemia. Hereditary hemoglobinopathy caused by mutation in beta globulin by replacement of glutamate residue with valine. Glutamate is replaced by valine. So in this condition, you get sickle cell anemia caused by mutation beta globulin by replacement of glutamate residue with valine, resulting in sickling of the cells. So autosomal recessive, it is an autosomal recessive, 6 months at the age, precipitated by dehydration, infection, hypoxia, it can cause vaso-occlusive disease affecting bones, hand-foot syndrome, lungs, chest syndrome, brain, strokes can be there. Spleen is autosplenectomy, it can cause. Then aplastic due to infection. Hereditary spherocytosis disease is seen in Caucasians in red cell membranes, abnormal shape, prone to splenic sequestration and destruction. This can lead to hemolysis, hyperbilirubinemia unconjugated, multiple pigment stones, jaundice, splenomegaly. Iron deficiency, serum ferritin is low, total iron capacity, chronic disease. Now 4 gram of iron is required, is present for 70% is in hemoglobin, 4% myoglobin. It is absorbed in small bowel. Iron is small bowel, that is duodenum. So iron deficiency anemia with no cause may be need to upper GI endoscopy or duodenal biopsy. Oral intake is 4 to 6 weeks to elevate the iron. Iron may be needed if difficulty in absorption, need rapid correction as low Primary hemochromatosis is seen runs in families, but in hemochromatosis they absorb too much and get rid of. Body stores excess hormone in the joints like liver and lung. Secondary hemochromatosis is the signs of anemia. Prussian blue iron stain. Prussian blue iron stain demonstrates blue granules. This is the question. Character inability to incorporate iron into RBCs leading to. Now this is Cori or a lactic sex cycle. The glucose is converted. What is normal? There are two types of cycles. One is Cori cycle when there is anaerobic respiration, and Krebs cycle when aerobic respiration. Muscles generally have got aerobic respiration, and RBCs has got Cori cycle. What happens? Glucose is converted to pyruvate into lactate whenever there is anaerobic type of. Then this lactate and pyruvate goes into the liver, and lactate is again converted back to glucose. So lactate to glucose is in liver. Glucose to pyruvate and lactate in RBCs. Glucose is converted in aerobic metabolism to pyruvate and then to lactate and produce 2 ATP in muscle. This is in anaerobic whenever there is deficiency. Lactate and pyruvate converts to glucose 6 ATP in liver. Even in aerobic state, glucose is converted to lactate in erythrocyte as there is no mitochondria. So lifespan of RBCs and other cells, platelets 10 days, RBC is 120, platelet 10, RBC 120, neutrophil 7, and rest of the basophil is very few days. So coming to this acute phase proteins, CRP is increased during inflammation, complement is increased haptoglobin, ferritin, fibrinogen, and negative albumin, transferrin, binding proteins, negative proteins, binding proteins decrease, transferrin, albumin is decreased. Troponin T may also be increased after head trauma. This is also a question.